This episode of the Practice of Therapy podcast is brought to you by TherapyNotes. You can find out more about them by going to practiceoftherapy.com/therapynotes. Hello, I'm Corden Brewer, and welcome to the Practice of Therapy podcast, where we explore the business and clinical sides of running a private practice. Well, hello everyone, and welcome to the podcast. This is episode number 242, and so glad you've joined me. And if this is your first time listening in, glad you found us. Glad you're taking a listen, and hope you'll take time to follow us wherever you might be listening to the podcast. So my guest today is Betsy Byler, and I'm looking forward to you hearing from her because she's one of those people that is just really fascinating. One of the things that I realized when I started interviewing Betsy is that this is a topic I haven't done a whole lot with, and that is just around substance abuse. And I know for those of us that are in the mental health field, I think for a lot of us, we kind of separate mental health from substance use. And being a substance abuse counselor is different than being a mental health counselor or a marriage and family therapist and that sort of thing. But one of the things that Betsy brings out, and I think she just brings out brilliantly, is the fact that substance use is something that comes up a lot in sessions, and in particular, for those of us that work in areas where there might be a higher rate of substance abuse. But anyway, it's just a really, really great topic, and I'm so grateful to Betsy for being on the podcast and for us delving into this. I know that as I share in this particular episode, where I live here in East Tennessee, the opioid epidemic has been something that has been a pretty strong topic. And I was talking with someone earlier this week about how even heroin use is going up in a lot of the rural areas. And again, this is not anything new, this is not new information, but it's something that we deal with as therapists, and being able to know how to talk with clients about those kinds of things is something that I think we really need to kind of hone the saw with, or sharpen the saw rather, and really hone in on developing those skills. And so Betsy's putting together a program to help us all with that. So really looking forward to you hearing from her, and also just hearing her story of her private practice journey and how she landed where she's landed, as I like to say. But before we get to Betsy, I'd really love for you to go over and check out some of the free webinars we've got over at Practice of Therapy. And if you can go to practiceoftherapy.com/webinars, you can find out more about those free trainings and free offerings that we've got there. As I've said in previous episodes, we're continuing to add to that. But there's 4 up there now, one on how to accept insurance in your practice and if it's something that you should consider. Another one there about going from a solo practice to a group practice. Another one on using Google Workspace in your practice. And then the 4th one is just if you're in those beginning stages of private practice, on getting started in private practice and how you might do that and things that you need to consider. So I commend those to you. And again, you can find them by going to practiceoftherapy.com/webinars to find out more about all of that. So real quickly, before we get to my conversation with Betsy, I'd love for you to hear more from our sponsor of the podcast, TherapyNotes.
As your practice grows, the systems and processes you have in place will keep your practice running smoothly. That is why it is important to have an electronic health record system that is specific to mental health providers. TherapyNotes is a complete practice management system with everything you need to manage patient records, schedule appointments, meet with patients remotely, create rich documentation, and bill insurance right at your fingertips. Their streamlined software is accessible wherever and whenever you need it. They are who Gordon uses in his practice. And did I mention that they are one of the top-rated EHRs for mental health private practices? Their support is also second to none. Be sure to check them out at practiceoftherapy.com/therapynotes. Be sure to use the promo code GORDON to get 2 months free.
Hello, folks, and welcome again to the podcast. And I'm really excited for you to get to know Betsy Byler. Hi, Betsy. Welcome.
Thank you so much for having me.
Yes, I was really, really happy when Betsy reached out to me about being on the podcast. And I think we're going to cover a topic today that I don't know that I've covered that much on the podcast. But anyway, as I start with everyone, Betsy, tell folks a little bit more about yourself and how you've landed where you've landed.
Well, long ago, I thought I was going to be in youth ministry and worked with an organization called Young Life back in college. And a series of events that should have worked out job-wise kind of exploded spectacularly and directed me, and I wound up going to grad school. But I actually had thought of being a therapist many times as a teenager. I was in a lot of trouble, using a lot of drugs, and was very angry, and so was in therapy and saw 9 therapists before I found the right one for me.
Wow.
So I'm really passionate about finding the right person.
Mm-hmm.
Her name happened to be Betsy also. And there aren't really a lot of Betsy's running around in the world. But even at the time where I was really kind of a hot mess and very difficult and oppositional, she had a style that just worked. And it worked immediately. Within probably 15 minutes of meeting her, I was like, okay, like maybe we can do this. And so winding up in grad school was actually kind of the fulfillment of something I decided when I was 17. And I went from there to community mental health and spent most of my career in community mental health until 2019. And I loved that work and loved working with the populations I worked with, doing in-home therapy or outpatient substance abuse work. I did do some residential at a time, which I also loved. And most recently in private practice. Mm-hmm. And so I'm doing that since the fall of 2019. It's really weird to not be in charge of anybody or have budgets to deal with and audits and all the kind of stuff that goes along with running an agency. I didn't think, I thought I would miss it, and I really, really don't. And so entering into this private practice world, it's earlier than I expected in my career. I sort of expected to spend another 15 years or so in agency work, but this just sort of happened. And so now I'm doing private practice and home because of COVID, and love that in a way I never thought. I was really kind of anti-video therapy. Mm-hmm. Because I don't know, I'm a really relational person in general. Like, I feel like the relationship with our clients is the most important thing. And I didn't know how that could be done over video, but necessity being, the mother of invention, right? I actually love it. And I do EMDR over video, and that works really well. And I just don't know if I'm going back to in-person. So that's kind of how my career got to where we are today.
Wow. Yeah. And I think what you're talking about, just on the whole topic of doing virtual sessions and stuff, I think a lot of folks are finding that it's a good fit for them. And I think clients are finding that as well. I know I've had several clients that kind of got used to doing when we were meeting online. They'll say, well, can we meet online again? It's just easier for me. I don't have to drive into the office, and I can take my lunch hour and do therapy online. Mm-hmm. And so, I think it's an interesting thing.
It is. And it's my state finally made all the COVID allowances permanent, because that was the question, right? Like in Wisconsin, Medicaid wouldn't reimburse for virtual sessions until COVID. And so that was the question of when were they going to make that permanent? And they did. And so that, especially where I am, it's a really rural area. And lots of folks, I mean, I'm even out in the country. I'm, on 10 acres in the woods, and lots of people are really far out. It would take them an hour to get to the office. And it's extending therapy services in a way that people don't have to come to town, or if they have transportation struggles. And since a lot of the folks I work with do have transportation struggles, that's a huge deal. So it was such a shock to me. And I am fully admitting that I was completely wrong about video and virtual work.
All right.
And it's been huge, and I'm really grateful to be able to do it.
Right. Yeah. You mentioned, and again, I don't want to get us too far off on a tangent here, but where I live as well in my practice, we're surrounded by a pretty large rural area, and particularly people that are like on Medicaid, or people that have just struggle more socioeconomically. Transportation is a huge problem. They've got to have number one, be able to afford a car, and then there's no public transportation, all of that sort of thing. So it's
and where you are, you're serving that kind of that corner, right? And I imagine that there's just not a lot of services,
right?
And it's really challenging. And that's kind of where I am too. My office is in a in the city area of where we are, but my whole county is 40,000 people. So
right. Yeah.
It's pretty small.
Yeah. I get it. So, change gears a little bit. I know one of the things that you're real passionate about, Betsy, is just really making sure that therapists, those of us in the mental health field, have a better comfort level with dealing with clients or helping clients with substance use issues. And I think, I just kind of to be transparent here, in my practice, I've made it pretty clear that we're not substance abuse counselors. And so if we get people that are coming to us for that issue, we refer them to someone else. And so, but as you noted, as we were talking ahead of time, it comes up a lot for us in our session. So give us your thoughts on all of that, and just kind of where you're taking this and the things that you're really passionate about.
So there are levels of substance use work, and I've done both. I ran a program that was substance use, and we did medication assisted treatment, and people who were really far down the line in terms of using really heavily, involved with legal issues, all of that. And I think that's what people think of when they think of substance use work. And that is true. But a lot of it comes up with people who aren't that far down the line, and yet substances are a big deal. And I think a lot of therapists, at least for me, when I got into the field, even though I'm a person in recovery, I didn't know how to translate my substance use experience into clinical work. And we didn't get training on that. Most of us didn't. And I can't find any reason why we didn't, except that it's not on a licensing exam. And since it's not on the licensing exam, it's not in the school. And since it's not in the school, it's not in the licensing exam. And yet people don't often identify substance use as their primary problem unless they have to. When I was running a program, literally 96% of our clients in the substance use program were mandated in some way by court or legal issues. And so everyone else would go to mental health. They're coming in because they're depressed, or they have anxiety, or they're dealing with PTSD. And I think a lot of therapists, at least the ones I've spoken to, they sometimes will actively avoid it because they're like, I don't know what to do. I don't want to mess this up. I'm not comfortable with it. It feels really overwhelming. I don't know when to refer out. And so it can be really challenging. And I totally get that. One of the things I did was create it's a free substance use decision tree to help people look at and say, all right, where's my client and when should I refer out? Because there is a place, there is a moment where really, I do think for the majority of mental health therapists, this is above our pay grade. We need to, or beside our pay grade, we need to move it to a specialist area. But I think we can still really work with people. And I think follow through is better if they have a mental health therapist and a substance use specialist. That aside, I think there's a lot we can do. And I'm really passionate about the fact that I don't think we need certification. I don't think we need new modalities. I think that our skills already work just fine with substance use because frankly, there are not specific modalities for substance use. They don't exist. Like it's not a thing that you can go get trained in how to do this modality. Maybe motivational interviewing, maybe, but that's really useful elsewhere too. And so I feel like we can use DBT or IFS or EFT. I mean, we can use our skills already with substance use. It's just, we need information. We need to know what to ask, what it means, how to apply it, and when is too much for us.
Yeah.
And so that's kind of what I'm working on, is trying to encourage people that substance use truly is in our scope of practice. It is in our statutes, that it's part of people's lives. It's in the DSM. There's no distinction. And the distinction that's there in the field is really arbitrary. It's not based on anything. And this is the part that might sound a little arrogant, that I believe I know what therapists need to know, like the basics, like pulling it all together of all the stuff they could learn, because I supervised for 14 years and trained therapists and interns. And I figured out, what do they need? What do they need to know? And what don't they need to know? Because there's a lot of stuff that is floating around in my head, because I am like duly licensed, that I don't know that everybody needs to know. That's a little niche, like, yeah. But I think on an average basis, people who are drinking or smoking marijuana or whatever, there's a lot that we can do. And my goal is for people to feel confident and really competent, that when it comes up, they're not like, oh, I don't know, that they're feeling like, okay, I think I have the tools for this.
Yes. Kid, do you mind giving maybe some case examples, just as we think about that? Because I'm sure people are really, you got me curious about it. I mean, I would say, yeah, that there's so much that, particularly here in where I'm located in the Appalachian region, opioid use is just rampant. And it's that's no different than it is other places in the country, but there seems to be a kind of a connection between rural communities and opioid use and that sort of thing. So if that comes up, how do we address that with our clients? What are things that we need to keep in mind?
Well, and I think there's a couple different things. One is, in some areas of the country, like what you're talking about, opiates have become a giant problem. And part of that is all the stuff that happened in the 90s with the overprescribing. And I don't blame medical professionals for that. They were told outright that this wasn't addictive and that the risks were overstated. It was a huge thing. But now we have a bunch of people with chronic pain who have no idea what to do. But I think that when you have that, there are ways of, okay, how much are they using? How often? What's the withdrawal like? And these are the things I help people know, like, is this something you can work on or not? And if not, most people on opiates are terrified of going off because of the withdrawal. It's not even about not having the drug, so to speak, because it makes them high, because it doesn't make them high anymore. It just keeps them from feeling terrible. And nothing is worse than opiate withdrawal. In the drug world, there is literally nothing more painful or more difficult than opiate withdrawal. It won't kill them. They want to die often, but that's alcohol and benzodiazepine withdrawal that can kill you, not opiate withdrawal. I mean, certainly there are cases where someone might have a complication, but generally it's just so terrible that they can't deal. And the other thing that opiates do is causes what's called hyperalgesia, and it actually makes people more sensitive to pain. And so the pain pills actually make their pain worse over time.
Mm-hmm. Mm-hmm.
That can be corrected with sobriety. Like they can rewire their brain, but it takes a while and it's super painful.
Mm-hmm.
And so for us, we're talking about, first of all, setting some limits around like the therapy hour. And I'm talking to someone about, all right, how long can you go before, when you take this pill, before you go into withdrawal? They will be able to tell you. And that's when I want them to schedule their appointments, is just before that's going to happen. So I get them when they're not actively nodding out and falling asleep, and they're not sweating and in a lot of pain. And that's like kind of the first step of like, let's have therapy be a protected time.
Mm-hmm.
Right. Same thing with marijuana. I'll say, don't smoke within 4 hours of coming to see me. I'm not requiring sobriety. I'm not telling you what that has to look like. I'm just telling you, I need you present emotionally.
Mm-hmm.
And then, so let's say they're trying to manage cutting back. Well, let's take DBT, for instance. DBT has lots of skills, and I think almost all of them that can be used very easily with substance use, because people who are coming off of substances have very little distress tolerance, almost none. And their emotion regulation is also really compromised. Their relationships are typically really compromised as well, and they never live in the moment. It's always this future thing. And so if we take a skill like, there's a skill for distress tolerance about TIP, and it's temperature, intense exercise, paced breathing, and paired muscle relaxation.
Mm-hmm.
Well, those are all really useful in managing a craving. Cravings last like 8 to 15 minutes on average. It's kind of like a panic attack. And so someone in a substance use issue can use that to kind of push themselves through that. So like there's tons of skills that we have that can be really useful, and we just have to repackage it sort of. But
Mm-hmm.
DBT, if we think about borderline personality disorder, the result of that in symptoms is pretty similar to substance use. Lots of out of control, self-injurious behavior, right? Poor relationships, struggles with emotions, erratic behavior. I mean, all of that fits really well. And so DBT is a great option, but I think there are other places too. I mean, there's protocol for use with EMDR to use with addiction. So, I mean, there's a lot of what we already have is going to be really easily translated. It's just, I think people need permission. I think therapists need permission to say like, no, you're not going to mess this up. This really is okay.
Mm-hmm. Mm-hmm. Yeah. Yeah. I think somewhere along the way, I think we get kind of indoctrinated in graduate school is with, like you were alluding earlier to, you're supposed to have the training and the certification before you do any of this stuff. Well, there's a lot of stuff that we know just kind of intuitively how to do with people that we can do without having to have the credentials or the letters after our names and that sort of thing. And it's usually you have pretty good outcomes with that as well, because we've got it's kind of like how it works kind of thing.
Yeah, well, and I think we're all afraid. There are a few no-nos, right, in our big no-nos in our field. And one of them is practicing out of scope, right? We're always running up against that. And so part of what I start with when I work with people is trying to help them see like, all right, let's look at your license. Let's look at the statutes, and I'll show you that there's nothing saying this is out of our scope. There is nothing saying that. When you feel like it's out of your scope, there are places where I even would say, if someone is using opiates all day, every day, you need a specialist to help, because they're going to need some medication assisted treatment or something like that to get over this. But I would really encourage people to stick around and stay with the person, because most of the people we work with, there's underlying trauma. In all the cases that I've worked with substance use over the years, I think I've maybe had 2 that there was literally nothing. And I mean, I looked and I asked, but most people, they started out, and it could have been that it was depression. It could have been something traumatic in their life. It could be whatever. But once they're free of those substances, they're going to have all of that stuff, because we know time doesn't heal wounds, right? That's not how this works. And so that stuff's there. Substance use just puts it on pause. And as soon as you're sober, man, it just slams into you. But I think the therapists, I think all of us want to do really good work, and we don't want to mess people up, and we don't want to overstep. And I think my message really is there's a whole bunch of space before you're overstepping. There's a ton of it. Most of the substance use that shows up in our offices, because they're not mandated to see us for the most part, they are going to be within that scope that is appropriate for outpatient therapy.
Right. And I would say too, as I say to clients all the time, you don't necessarily have to be honest with me, but I want you to be brutally honest with yourself.
Right.
And I would say that most of the people that are coming to us for the issues you mentioned, anxiety, depression, trauma, all of those kinds of things, they know already that the substance use is a problem.
Right.
They just they know that. And so it's my experience has been, if you bring it up in session and you talk about it, it's almost like a relief that I can talk about this in a safe place.
It is. And part of that is, I can't tell you the number of folks who have had substance use issues that they weren't asked about it. And I don't think it's negligent on the therapist's part. I just think it's just not part of our intake process a lot of times.
Right.
But it was there. And so I have a lot of recovery stories that on the first Monday of the month, there always is a recovery story. And as people listen to them, they'll be able to hear just this recurring theme that they went in for depression, but, they weren't honest about their substance use, or they didn't get asked. And so they figured maybe this wasn't the place to tell somebody, or somebody was like, oh, that sounds pretty normal, when maybe their alcohol use wasn't normal.
Right.
And so I spend so the podcast really is about giving people information about a specific thing that they need to know.
Yes.
Right.
Yes.
Whether it's about assessment or a substance or whatever the case may be. The course that I'm launching in the fall is a comprehensive group program that's 6 weeks, kind of a small group setting, maybe 12 people. And I'm going to take them through, this is assessment. This is how you apply it. This is how you apply your skills based on your theoretical orientation, really trying to make sure when people leave that they are, okay, I know what to do. And then there's consultation calls for 6 months. There's one each month. There's 6 group consultation calls each month, if they wish, to discuss cases and talk about problems that came up so that they can really implement it. Because as you probably know, when we go to training, if we don't implement what we learn,
right,
it's gone.
Right.
Because that's how it is. We get these tools, but if we can't practice them, it sort of goes into the background. And it's not that it wasn't valuable. It's just, I don't know, we get going and hit the ground running and just forget those things.
Right. So, Betsy, I want to be respectful of your time. And I know that we could spend all day talking about this topic, and I love it. Tell folks how they can get in touch with you, your website, and most importantly, the podcast, or tell folks where to find that.
Sure. So my website is betsybyler.com, and on there is the podcast called All Things Substance, and you can find it on all the podcast platforms. There's 93 episodes now, and you can find it by topic or by substance or whatever you're looking for. And if anyone had an idea, I've gotten lots of listeners sending me ideas about, hey, would you talk about ADHD medication in people who have abused stimulants? Yeah, sure. Absolutely. Or specific things that show up in their practice. And so they can find me there. And then, so the podcast comes out every Monday. There is an event coming up. I'm not really sure when this will come out, that we're doing with Guy McPherson and a colleague of mine, helping therapists work with trauma and substance use without the burnout. And that's going to be on August 16th. And people can find the replay there. But we know that most therapists who are dealing with trauma and heavy issues can feel burnout at times.
Sure.
And I know that I'm asking everybody to consider adding something more. And that feels like a lot.
Sure.
And so the message is, how do we help people do this, but also take care of themselves and really treat their burnout and compassion fatigue and even prevent it by something more than just a little self-care here and there. And so those are kind of the things that are going on. And you can find that on the website, and people can always contact me at Betsy@BetsyByler.com. You can email me. I'd be happy to answer any questions that anyone has.
Well, Betsy, I really have enjoyed our conversation, and I hope we'll be able to reconnect again and talk more about this very needed topic. Well, again, a big thanks to Betsy for being on the podcast with me. And be sure to check out her things. She's got some great stuff, BetsyByler.com. And be sure to listen to her podcasts and think about following her wherever you might be getting your podcast as you do with this one. So be sure and check that out. I'm really looking forward to kind of delving into that and just really kind of getting some more knowledge about how to help those clients that are really struggling with substance use. And Betsy really has the heart for it. And I'm glad that she's out there and doing the work that she's doing in this whole space. And also, as I mentioned at the beginning, be sure and check out the free webinars that we've got available at Practice of Therapy. And you can find them by going to practiceoftherapy.com/webinars. And those are automated webinars that you get to pick the time at which you watch it. And so it's a little more convenient that way. But those are there for your taking and to learn a little more about the different aspects of being in private practice. And again, big thanks to our sponsor of the podcast, TherapyNotes. You can find out more about them by going to practiceoftherapy.com/therapynotes. And if you go to that link and you use the coupon code or the promo code Gordon, just GORDON, you can try them out for 2 months for free. So they're who I use in my practice, and I absolutely love them as an electronic health record system. And also the fact that they are really one of the top-rated electronic health record systems for mental health providers. They're just great to use, and I'm glad that they're on board with me here and sponsoring the podcast. So that's it, folks. Do take time to subscribe to the podcast, but what I really mean is follow the podcast, depending on which podcatcher you're listening to this on. And take care. Have a great week and weekend ahead. You have been listening to the Practice of Therapy podcast with Gordon Brewer, part of the PsychCraft network of podcasts. Please visit us at practiceoftherapy.com for more information, resources, and tools to help you in starting, building, and growing your private practice. And if you haven't done so already, please sign up to receive the free Private Practice Startup Guide at practiceoftherapy.com. The information in this podcast is intended to be accurate and authoritative concerning the subject matter covered. It is given with the understanding that neither the hosts, guests, or producers are rendering legal, accounting, or clinical advice. If you need a professional, you should find the right person for that.